Luis.
So I will start now.
Yes, yes, please.
Okay, so welcome everyone. So to the fifth AERF research seminar. So this time we will focus on the periendoscopic management for the antithrombotics, which is a very, very important topic nowadays, especially we are facing the increasing amount of these drugs used in our daily practice. So today we are very happy to have a very strong team for the speakers and the panelists. So for the panelists, we have Professor James Lau from Hong Kong and also Professor Hamo Chiu from Taiwan. And we have two star speakers as well. So I think they need no further introduction, but still is my job. So the first speaker will be Professor Noriya Uedo from Osaka International Cancer Institute. So I think he recently lead a RCT on the antiplatelet use during the gastric ESD. So today he will give us some insight on the management of antiplatelets during the perigastric ESD. So may I now pass the time to Uedo Sensei?
Okay, thank you, Luis, for introduction. And then thank you, James, for inviting me to this seminar. So, okay, so as Luis said, recently we published the paper, so I want to share the result for your discussion. So topic is management of antiplatelet during perigastric ESD. So basically the management of antithrombotics during endoscopic period is based on a balance between risk of bleeding and then risk of thromboembolism. So usually it's really depend on the patient's thrombotic risk and then procedure bleeding risk. So today I'm talking about high risk procedure such as gastric, meaning gastric ESD in low thromboembolic risk patients. So this is actual how to manage aspirin during perigastric ESD period in low thrombotic risk patients. So our Japanese guideline recommend consider discontinuation for 3 to 5 days before the procedure. And ASG guideline recommend continuation. And then British guideline recommend continuation. And American College Gastroenterology, College of Gastroenterology guideline recommend discontinuation could be considered. And then APAGE and APSDE guideline recommend discontinuation. This describe that especially in Asian country, we are doing a lot of gastric ESD. So this procedure must have ultra high risk of bleeding. So regarding this risk of procedure, bleeding risk of the procedure, APSD Asian guideline recommend discontinuation. So little bit controversial. And especially Japanese guideline issued in 2004, a very long time ago, they recommend all antithrombotic should be discontinued because of risk of bleeding. But 2012 guideline recommending consider changing this recommendation to consider discontinuation for low thrombotic risk patient, and then for high thrombotic risk patient, from change the recommendation from discontinuation to continuation. So the management is more prioritize risk of thromboembolic risk rather than risk of bleeding. So that is really background of this study. And after that, such kind of changing of policy, many observational study regarding about not so much difference, no statistical increase of the bleeding compared to discontinuation. So such many observational study was published. And then meta-analysis was also published. So according to these meta-analysis of observational study, most of the study conclude that the continuation does not increase bleeding, not significantly. So that is the background. So as I mentioned, Japanese guideline recommend interruption, discontinuation of low-dose aspirin during peri-procedure period of ESD for perigastric cancer in low thrombotic risk patient. But if we really prioritize the anti-thrombotic effect of low-dose aspirin, maybe if we can continue, if it does not really increase the bleeding risk, we can continue low-dose aspirin. So we can really sustain, maintain the anti-thrombotic effect peri-procedural period like this. So this is our background and hypothesis. So we conducted the prospective randomized control non-inferiority randomized control trial. And inclusion criteria is a patient with gastric mucosal neoplasia taking low-dose aspirin. Patient was defined as a low risk for thromboembolism according to Japanese guideline. So age 20 years old or more, and then performance status, enough performance status, and getting written informed consent. And exclusion criteria is a remnant or recurrent lesion or concomitant intake of other antithrombotics or NSAID, and those who have a major organ failure. So this is actually a high risk condition defined in JGS guideline. So recent stenting or recent stroke or severe arterial stenosis in image, these are regarded as a high risk condition. And then those who is not fulfill this high risk condition and taking low dose aspirin is regarded as a low risk condition in JGS guideline. So we enroll such low risk patients. And then patient was, before randomization, it is stratified according to institution, tumor location, size, and the presence of ulcer scar. And then discontinuation group, which is recommended in guideline, they stop aspirin 5 days before and then started 3 days later after the procedure. And next day, we perform a second look endoscopy. And then 8 weeks later, we also perform endoscopy to check the ulcer healing. And then continuation group, the patient continuously took aspirin before or after ESD. And then primary endpoint was ESD-related major bleeding, which is sum of massive intraprocedural bleeding that require transplant transfusion or something, and then delayed bleeding. And as I mentioned, we have done second look endoscopy, but the second look like a oozing or bleeding during second look endoscopy or intervention were not regarded as a endpoint, ESD-related bleeding. So only massive intraprocedural bleeding and delay bleeding after ESD were regarded as a ESD-related major bleeding. And secondary endpoint was the incidence of thromboembolic events and other adverse events. And sample size was calculated according to assumed bleeding rate of continuation group of 10% and then discontinuation group of 5%. So non-inferiority margin was regarded at 5%. According to this sample size calculation, the required sample was calculated as a 560. And then we get IRB approval and then register in a study registration. So actually this is the randomization table. So after some excluded patient, ESD was performed in 273 for discontinuation group and then 270 patients in continuation group. And then bleeding developed in 21 in discontinuation group and then 28 in this continuation group. An ITT analysis was performed for all allocated patients, and then per protocol analysis was performed for those who fulfill or completed study protocol. And this is a background data. So age, gender, or background thrombotic disease, comorbid disease, or history of peptic ulcer, H. pylori status were well balanced in each group. And then tumor location, tumor factor was also well balanced in those groups. And this is actual primary endpoint. So bleeding developed in 7.6% in discontinuation group, and then 10% in continuation group. So risk difference was only 2.5%, but it did not fulfill the non-inferiority criteria. Predefined non-inferiority criteria. So result was a little bit negative. So bleeding, delayed bleeding, ESD-related bleeding it's increased beyond our predefined non-inferiority margin. And actually, this is a per protocol analysis. Per protocol analysis, more difference of bleeding was more evident. And then it also did not fulfill the non-inferiority margin. So like this, so upper limit of 90% exceeded our predefined non-inferiority margin. So we could not prove non-inferiority of the continuation of low-dose aspirin. And this is actual Kaplan-Meier curve for ESD-related major bleeding. So especially in per protocol analysis, the difference becomes more obvious. Usually, superiority study, we usually appreciate more intention to treat analysis, but because those who did not fulfill per protocol treatment, so that it reduce the group difference. But in non-inferiority study, usually such reduction of the group difference can be overestimation, risk of type 1 error. So usually per protocol analysis is more important for non-inferiority study. So such non-inferiority study group difference increasing risk of bleeding becomes more obvious. So this type of trend really support our negative result of non-inferiority study. And then this is a subgroup analysis. So there's not so much characteristic trend for each subgroups for the regarding to the bleeding tendency. And this is actually secondary endpoint, thrombotic event. So we really experienced that even continuation group developed thromboembolic events. So one patient in continuation group developed mild cerebral infarction, which is confirmed by MRI. And then another patient in continuation group developed develop delay bleeding and then could not stop bleeding by endoscopy. So she require emergency surgery. And then after the surgery, she developed cerebral infection with infarction with hemiplegia. So the other adverse events was not difference in each group. So this is our actual result. So this is so our study showed that the continuation of low-dose aspirin really increase the delay bleeding, ESD-related major bleeding beyond our expected threshold. And recent large-scale observational study also support this finding, our finding. So according to this data, which include 9,200 patients, so low-dose aspirin use increased the delay bleeding rate to odds ratio of 2.24, and then discontinuation decreased the delay bleeding to 0.67. So taking aspirin and then discontinuation of antithrombotic is included as a risk prediction score. Like this. And probably another discussion point is our data was negative. Probably non-inferiority margin 5% was little bit too small. But as I mentioned, at the time of study design, Japanese guideline changed the policy to discontinuation to continuation for high risk, high thromboembolic risk patients. And then at that time, we felt that the continuation of aspirin did not increase much delay bleeding. And also many observational study also show that the non-significant increase of delay bleeding rate. So we set the non-inferiority according to such kind of clinical decision. We set the non-inferiority margin to 5%. And usually antiplatelet agent nowadays are TNP, so maybe more evidence may be required for this type of drugs as well. And another discussion point is recently we some closure technique of the wound is developed. So if we can combine such kind of closure technique, maybe we can continue some antiplatelets and then we can achieve some sustained antiplatelet antithrombotic effect during perigastric ESD period. But anyway, in conclusion, interruption, discontinuation of low-dose aspirin is recommended during perigastric ESD period in patients with low thrombotic risk according to our study result because non-inferiority of bleeding rate for gastric ESD under continuation low-dose aspirin was not proven. Thank you. Sorry. And then this is the maybe last take-home message. So I really understand that we cannot really fulfill the two difficult aspect, reduction of the risk of bleeding and then reduction of embolic risk. So we cannot really fulfill, make the both risk to zero. So still individual assessment and then individual management with multidisciplinary doctor like a cardiologist or neurologist is important. And another important aspect is evidence of this topic is very limited, but usually the guideline recommendation is made based on some expert opinion or limited evidence. But guideline has a social legal power. So I think very important to understand what is described in guidelines. And then if you really try to make something different written in guideline, I think it's better to describe why, reason why or something in your medical report, I think, medical record, I think. That is our message. Thank you.
Thank you, Noriya, for your sharing. And this is also a very important message with the new evidence. So as previously discussed, we will move the discussion to the end of two talks. So now I would like to invite Professor Yoji Takeuchi from Kindai University in Osaka, Japan. So I also think he has published a very important paper in the Annal of Internal Medicine before on the anticoagulation and polypectomy. So today he is going to share with us on his insights on the peri-colonic polypectomy management of anticoagulants. So Yoji, the floor is yours.
Thank you, Luis, for the kind introduction, and thank you, James, for inviting me to this. Sorry, just a moment. For this awesome workshop. Today I will talk about the procedural management of anticoagulants in colorectal polypectomy. They are my COI. And before I begin, please allow me to share a bit of personal news. I worked with Noriya for many, many years at the Osaka International Cancer Institute. And then in 2023, I moved to Gunma University. And Gunma is presently rural and very comfortable place to live. But this April, I returned back to my hometown, Osaka, and I'm now working at Kindai University. So Noriya demonstrated in the setting of gastric ESD that continuing aspirin increases the risk of bleeding. This may sound like an obvious observation, but actually proving it in a randomized control trial was a very important contribution. In other words, we always have to weigh a bleeding risk against the thromboembolic risk and strike the balance between the two. Gastric ESD performed for cancer or cancerous lesions, so a certain level of procedural risk is acceptable. But what about the colon? Perhaps everyone knows that colorectal polypectomy is effective, but it is ultimately a preventive procedure. We therefore need to minimize both the procedural risk and the burden of the patients as much as possible. Appropriate management of anticoagulants is key to safe and effective polypectomy. Today, I will introduce two multi-center RCTs that we conducted on colorectal polypectomy. The first is the CPAC trial, which evaluated the coast-near polypectomy as a management strategy for polyps smaller than 10 mm in patients taking warfarin or drugs. The second is the MADWARS trial, which investigated the optimal timing of drug interruption when managing small to medium-sized polyp in patients on drugs. Let me start with the CPAC trial. As you know, over the past decade, or so-called polypectomy has become so widespread that it has been called the cold revolution, enabling safer management of colorectal polyps than never before. You know, one of our discussant, today's discussant, Hamo, showed the safety of cold snelling in very large RCT. I also consider this paper to be one of the landmark papers on cold snelling. Dr. Horiguchi from Nagano Prefecture in Japan conducted a single center randomized control trial comparing the hot snare polypectomy and cold snare polypectomy in patients taking warfarin. Patients were randomly allocated to either hot snelling or cold snelling, and importantly, without discontinuation of warfarin. The results showed 14% delayed bleeding with hot snelling and 0% with cold snelling. This study established the safety of cold snelling by demonstrating that it could be performed without discontinuing warfarin, and it clearly showed that cold snelling is a safer procedure than hot snelling. Although this was a landmark RCT, it has several limitations: a single-center design, a small sample size, and importantly, continuing warfarin was not the standard of care at that time, and also drugs were not evaluated in this study. To address all of these issues, we designed the CPAC trial, a multi-center RCT comparing the then standard approach of hot snaring with heparin bridging against cold snaring with continued oral anticoagulation, including both warfarin and drug users. The aim of this study was to establish the standard of care for the management of small colorectal polyps in patients receiving oral anticoagulant therapy. This was a multi-center prospective open-label randomized control trial with 30 tertiary institutions across Japan participating. Eligible patients were 20 to 80 years old with good performance status taking warfarin or drugs and known to have non-pedunculated colorectal polyps smaller than 10 mm. Patients were randomly assigned to two arms: the standard arm, standard of care arm, consisting of hot snaring with heparin bridging, and the experimental arm consisting of cold snaring with continued anticoagulation. In the standard arm, heparin bridging was initiated prior to Polypectomy. Heparin was then discontinued 3 hours before hot snaring, restarted 3 hours afterward, and the oral anticoagulant was resumed the following day. In the experimental arm, patients simply continued their oral anticoagulants, underwent cold snaring, and then continued their regular medication without interruption. The primary endpoint was the major polypectomy-related bleeding, defined as the composite of either poorly controlled intra-procedural bleeding requiring transfusion, surgery, or interventional radiology, or post-polypectomy bleeding requiring endoscopic hemostasis in 28 days after the procedure. The secondary endpoints included procedure time, intraprocedural bleeding requiring hemostasis, and so on. For the sample size calculation, we assumed a major bleeding rate of 10% in the standard arm and 3% in the experimental arm. Because the experimental arm eliminates the need for heparin bridging, we considered it sufficient to demonstrate non-inferiority for the new approach to become the standard of care. With a non-inferiority margin of -5%, an alpha of 0.05 and a beta of 0.10, 70 patients per arm were required. According for dropouts and ineligibility at 20%, we plan to enroll 90 patients in each arm. A total of 184 patients were enrolled. After several exclusions, 168 patients were included in the full analysis set. And the randomization produced well-balanced arms: sex, age, body mass index, and the type of anticoagulants used were all evenly distributed. Overall, about 30% of the patients were on warfarin. A total of 286 lesions were detected and treated in the standard arm and 325 in the experimental arm. Prophylactic clipping was performed significantly more often in the standard arm. The primary endpoint, polypectomy-related major bleeding, occurred in 12.1% of patients in the standard arm and 4.7% in the experimental arm, a risk difference of 7.3%. The lower limit of the 95% confidence interval exceeded our predefined non-inferiority margin, thereby demonstrating non-inferiority. In other words, continuing oral anticoagulation with cold snaring did not increase bleeding. Looking at the primary endpoint in more detail, there was no severe intraprocedural bleeding in either arm. The endpoint was entirely driven by post-polypectomy bleeding requiring endoscopic hemostasis. When stratified by the anticoagulant type, both the warfarin and drug subgroups in the standard arm had a bleeding rate of 12%, In the experimental arm, however, no bleeding occurred in the warfarin subgroup, while 7% of the drug subgroup experienced post-polypectomy bleeding. For the secondary endpoints, procedure time was significantly shorter in the experimental arm. Intraprocedural bleeding requiring endoscopic hemostasis and hemorrhagia that did not require hemostasis both tended to be slightly more common in the experimental arm. In this study, we have hospitalized all patients since we regarded them as being at high risk of bleeding. The length of hospital stay was significantly shorter in the experimental arm, and patients reported adverse events such as abdominal pain and bloating also tended to be less frequent in the experimental arm. In summary, because management was simpler and bleeding did not increase, we concluded that co-snelling with continued anticoagulation can serve as the standard of care for polyps smaller than 10 mm in patients taking oral anticoagulants, with the added benefits of shorter procedure time and shorter hospital stay. However, if we look again at the results by anticoagulants type, the findings differ between the warfarin and drugs. For warfarin, consistent with Dr. Horiuchi's single-center study, there was no post-polypectomy bleeding at all, pivotal results. For drugs, by contrast, 7.3% of the patients experienced post-polypectomy bleeding, which we considered too high for the treatment of small polyps. So the question became, for drugs, how should we manage the peri-procedural period? This question led us to the design, our second RCT, the Madowazu trial. Let us first look at the pharmacokinetics. Drugs show a rapid onset and offset, which is very different from warfarin. Based on these pharmacokinetics properties, the JGES guidelines recommend a one-day cessation of drugs, that is, skipping only the dose on the morning of polypectomy, and resuming the next morning if no bleeding has occurred. Now here is a concept I would like to emphasize, because it changes how we should think about this question. Drugs have a rapid onset and offset, unlike warfarin. This simple pharmacokinetics fact has an important clinical implication. The timing of cessation determines which type of bleeding it prevents. Stopping drugs before the procedure reduces the intra-procedural bleeding. Stopping drugs after the procedure reduces the delayed post-procedural bleeding. These are two different problems addressed by two different timings. Now remember what we saw in CPAC. Even with drugs continued, there was no severe intraprocedural bleeding. This suggests that procedural cessation is not the critical factor. What really matters is how we manage drugs after the procedure to prevent delayed bleeding. Based on this reasoning, we proposed a new strategy: continue drugs on the morning of the procedure because any intraprocedural bleeding can be managed during the colonoscopy, then discontinue drugs on the morning after the procedure and resume them on the second morning. This should reduce the risk of post-polypectomy bleeding. To summarize the rationale, the Japanese guidelines recommend a one-day cessation of drugs before polypectomy. However, our previous study found no severe intraprocedural bleeding in patients who continued oral drugs during co-snare polypectomy. This suggests that post-procedural bleeding is the main clinical problem. We therefore hypothesize that shifting the cessation period to after polypectomy might be more logical and potentially safer. And the aim of the next Madowazu trial was to determine the optimal timing of drug cessation in the peri-procedural period of colorectal polypectomy. The study was designed as a multi-center prospective randomized open-label non-inferiority trial conducted at 33 Japanese institutions. Eligible patients were 20 to 80 years old with good performance status, taking drugs, had preserved organ function, and were scheduled for polypectomy, including cases in which polyp information was not yet available. In this trial, the standard arm followed the Japanese guideline recommendation of a one-day cessation of drugs before polypectomy, while the experimental arm followed a one-day cessation of drugs after polypectomy. After stratification, patients were randomly assigned to one of these two arms. And the primary endpoint was as the same as in the CPAC trial, major polypectomy-related bleeding defined as composite of either poorly controlled intraprocedural bleeding or post-polypectomy bleeding requiring endoscopic hemostasis within 28 days after the procedure. And the secondary endpoints were major intraprocedural bleeding and minor delayed bleeding and so on. Based on our previous study, we hypothesized that the incidence of the primary endpoint would be 8% in the standard arm and 4% in the experimental arm. The non-inferiority margin was set at -5%, with a one-sided alpha of 0.05 and a beta of 0.10, accounting for a 20% of withdrawal and the ineligibility rate, and the possibility of patients without polyps. The target enrollment was set at 200 patients per arm. Recruitment was terminated once regular monitoring confirmed that more than 120 patients in each arm had undergone polypectomy. And here's a patient flow. A total of 358 patients were enrolled. Ultimately, 159 patients in the standard arm and 155 in the experimental arm were included in the analysis. Baseline characteristics were well balanced between the two arms in terms of sex, age, body mass index, and type of drugs. A total of more than 600 polyps were removed in each group. The number, size, location, and morphology of the resected polyps were also well balanced between the two arms. There were no significant differences between the arms in the method of polypectomy used or in the use of prophylactic clipping. Now for the most important results, the primary endpoint. The incidence of the primary endpoint was 4.4% in the standard arm and 3.2% in the experimental arm, with the standard arm showing a 1.2% higher rate. The lower limit of the 90% confidence interval of the risk difference was -2.4%, which exceeded our predefined non-inferiority margin, thereby demonstrating non-inferiority of the experimental arm compared with the standard arm. Notably, no severe bleeding occurred in either arm. Only major delayed bleeding events contributed to the primary endpoint again. Turning to the secondary endpoints, intraprocedural bleeding requiring endoscopic hemostasis occurred in 3.4% in the standard arm and 7.0% of the experimental arm. The rate was significantly higher in the experimental arm, but hemostasis was successfully achieved in every case. Minor delayed bleeding, which did not require endoscopic hemostasis, occurred in 6.3% of the standard arm and 3.9% of the experimental arm, a trend favoring the experimental arm, although not statistically significant. No thromboembolic events occurred in either arm. Let me summarize the pros and cons of the two timings of drug cessation. Major delayed bleeding, which required endoscopy intervention, tended to occur more frequently in the standard arm, although the difference was not statistically significant. A major intraprocedural bleeding requiring endoscopic hemostasis was more common in the experimental arm, but was controllable in every case. Importantly, in routine clinical colonoscopy, we often do not know in advance whether a polypectomy will be needed. The standard approach, therefore, always requires pre-procedural drug cessation, whereas our new strategy allows us to avoid unnecessary drug interruption in patients who ultimately do not need polypectomy. Before I conclude, let me place our results in international context. The BSG and ESG guidelines currently recommend discontinuing drugs 2 to 3 days before high-risk procedures such as colorectal polypectomy and resuming them 2 days afterward. This cohort study by Ladel and colleagues showed that intraprocedural bleeding occurred in about 10% of high-risk procedures, even when the timing of drugs interruption followed the BSG-ESG recommendations. Delayed bleeding occurred in about 7% of cases when the drug disruption followed the recommendations. Specifically, the authors reported a delayed bleeding rate of 8.8% for colorectal polypectomy. Thromboembolic events, on the other hand, were very rare, only 2 events, both of which were transient ischemic attacks. Although a direct comparison with the 8.8% delayed bleeding rate from that cohort must be made cautiously, our MADWARS trial showed a delayed bleeding rate of 3.8% with 1-day cessation around polypectomy. So bleeding certainly did not appear to increase. Furthermore, stopping drugs only after polypectomy has an important practical advantage for screening patients in whom the presence of polyps is unknown in advance. There is no need to interrupt drugs before colonoscopy. Only patients who actually undergo polypectomy need to interrupt their medication. This both simplifies peri-procedural management and potentially increases the overall intensity of drug therapy. In conclusion, a 1-day cessation of drugs after polypectomy is a feasible approach to peri-procedural management of these agents. And to summarize, these two RCTs suggest that for small polyps, co-snaring with continued warfarin can be considered the standard of care. For drugs, on the other hand, temporary interruption still appears preferable. When interruption is needed, a 1-day cessation produces a sufficiently low bleeding rate compared with the previous reports, and cessation after polypectomy seems to be a reasonable approach. And thank you for your kind attention. Thank you so much.
Thank you, Yoji, for your excellent sharing. I think I learned a lot as well. So now the symposium is open for discussion. So may I now also invite our panelists, Professor James Lau and also Professor Hamo Chiu, for any questions or discussion first.
Perhaps I can start. First, I'd like to congratulate Yoji and Noriya for excellent initiatives and very, very nice trials. I'm sure these trials are going to be very much cited. I read Noriya's publication in American Journal of Gastroenterology. I have several questions for Noriya. The first is why a non-inferiority trial? I think this is based on the Japanese Society recommendation. So your hypothesis is to say that the interruption of aspirin is non-inferior to continuation. I think that was the hypothesis. The other thing is we had earlier discussed. I think the conclusion must be that aspirin should be stopped, because if you see the 2 patients who has very severe complications, cerebral infarctions after major bleed because of continuation of aspirin. So people go away, have the misconception that if you discontinue aspirin and if you continue aspirin, patients are actually protected, but quite the contrary. If they should develop major bleeding, and that could actually lead to very serious cardiovascular complications. So I think that's the message that I come away reading Professor Uedo's paper, and I happen to think that also in the design of such trials, the primary endpoint should always be cardiovascular risk. Of course, this is difficult because you look at large observational studies, the 30-day risk is of a major CV event is only between 1% to 2% over 30 days. So I think we do need a major trial to look at a much larger trial to provide us with an answer. But for now, I think a continuation of aspirin is probably not so safe in certain patients. But I think that it's actually very difficult to be conclusive. With regard to Yoji's papers, they were actually excellent papers. The one in the Annals Internal Medicine, and people now are very convinced that cold snaring is very safe in polyps smaller than 10 millimeters, even with patients on NOAC. This is, of course, a continuation of Hamu's excellent large multi-center study from Taiwan because of the more superficial cutting of the mucosa that actually you don't cut into larger vessels, and then cold snaring is the way forward, and even in patients who are actually on NOAC. And I also very much like Yoji's second paper, and I think he's actually introduced a very refreshing approach. When we do colonoscopy, a lot of patients do not actually need polypectomy, and then we unnecessarily stop NOAC. And I think the on-demand approach, I call this an on-demand approach, and only if you do polypectomy, then you stop for a short period of time. I think that's actually quite a refreshing approach, and I think this is a approach forward. One thing I'm not certain about is I think the patients you enroll were in fact patients who were known to have polyps. So I think perhaps we could apply this approach in a broader population where we just do screening colonoscopy and in a larger sample size and looking at the cardiovascular outcomes. I think these were my comments. I often find non-inferiority trial very difficult to interpret, but I happen to see many non-inferiority trials coming out from Japan because it's often very difficult and then sometimes it's often very difficult to interpret because there's no absolute no difference. There's always a certain difference. So that's my thinking. I've tried to avoid doing non-inferiority studies when all possible. These are my comments, Louis.
Yeah, thank you, Professor Lau. So any reply or additional comments from Noriya and Yoji?
So, yeah, I think James mentioned probably most important endpoint is thromboembolic events.
Correct.
Because all drug is, administered to prevent such events. But actually, when I conducted this trial, I think interpretation very different, and then the patient background is also very different. I mean that the risk of thromboembolism as well. So very difficult to conducting the randomized trial in this, and also event is very small. So I don't know how we can get good evidence or recommendation in this aspect. I think even guideline is based on very limited evidence. Like most of the referred article is observational study, and then just expert discussing about their opinion, cardiologist or endoscopist. So yeah, that is our my personal thinking impression. Very difficult to conclude.
But in areas outside endoscopy, there are trials in general surgery, for instance, and also in coronary artery bypass.
Oh.
Yeah, where they actually conducted large multi-center scale studies. Yeah, very difficult to do, but I think and hopefully we will see one soon enough that within endoscopy we'll be able to provide conclusive evidence.
I see.
Yeah,
Yoji,
Yeah.
what do you think about British? You said you saw that British guideline usually recommend to stop 3 days before
Yeah.
procedure.
It's very long. But in that observational study, if they shorten the withdrawal period, then the risk of bleeding will increase. So at least so far they don't consider the 1 day cessation is safe. So I wanted to show two things in my second RCT. One is that the 1 day cessation is safe, not so challenging. It's acceptable, I think. Still 3.8% related bleeding is a little bit high, but I think it's acceptable. And the second is that drug cessation after polypectomy is reasonable. I'm very happy to hear the naming of the on-demand strategy. Thank you, James. And now I'm writing a paper and submit that to GUT, but unfortunately it's not accepted. But I will revise using the on-demand strategy.
Yes, I think it's especially in this topic, I think we should always see the like interaction between the cardiovascular risk and bleeding risk as highlighted in Noriya or original slides. So I have a few questions. For example, in the APSDE guideline, like published in 2018, I think they try to classify different endoscopic procedures according to the bleeding risk. And
Yes.
SD was kind of like a group classified as the ultra high risk group. But from my clinical observation, I think the bleeding risk from upper GI and lower GI ESD are quite different. So for upper
yeah.
GI, which is more vascular and more
Yes.
delayed. So, do you think the way forward should be like further subdivided into upper GI ESD and lower GI ESD? And
Yeah.
in that case, what will be the recommended strategy? I would also like to hear the strategy in Japan, because locally in Hong Kong for ESD, we still continue aspirin because we think this is safe drug, and it's also not absolutely required by the guideline. And of course, on the contrary, for anticoagulants, we will interrupt it. So I wish to hear the viewpoints from
Yeah. So, yeah, good point. So, I think ACG guideline classify the bleeding risk of procedure according to incidence of DA bleeding, and then 1% is less than 1% is low risk procedure, and then more than 1% is high risk procedure. And then I think current Japanese web-based prospective large-scale study, cohort study, show that gastric ESD bleeding incidence is 4.4 or around 5%. So it's quite high compared to how colorectal ESD. Do you know, Yoji, do you know the incidence of delay bleeding? Less than around two or something.
Yes, around 2.
So I think the gastric ESD is very 1 in 25 or 1 in 20 develop delay bleeding. And then this study show almost nearly 10% if we continue. So more than, around 2 times. So I think gastric ESD is really can be regarded as ultra high risk procedure. So maybe colorectal ESD maybe a little bit, much lower incidence of delay bleeding. So I think we can subdivide it into lower colorectal ESD and gastric ESD. So gastric ESD and also James mentioned sometimes bleeding can also cause more subsequent adverse events, serious adverse events. So I think it's better to stop, or maybe we have to develop more good preventive method for
Yes.
delay bleeding. Yeah, that is my comment.
Yeah, just like you mentioned, the prophylactic closure, maybe to go, because we have so many good closure device now.
We should hear comments from Hanmo.
Yes.
Oh, yes. Thank you, James. So, yeah, I already enjoyed the presentation from Noriya and the Yoji for the, guideline changing clinical trial. I think this is very, very important. So, first of all, I would like to mention that the aging population is a very important population change in Asia Pacific. For example, in Taiwan, the population size of people aged 50 to 75 double in the past 2 decades. So in the future, we are expecting more people using DOAC, using aspirin, and using a dual antithrombotic agent. So I think the whole world will become very, very complicated. So what I want to ask is the implementation issue in your unit. So for example, in our unit, we have a colonoscopy that arranged by non-GI doctors, and they ask the patient to stop aspirin or to stop Provix before the procedure. However, in the winter season, we experienced one case who had a brainstem stroke before the procedure. So this is a disaster, actually. So I want to ask in your unit, if the colonoscopy was arranged by non-GI doctor, do you have any kind of system, or you have a app embedded in your EHR, or that the non-GI doctor can check the guideline, or we can give advice to non-GI doctor to ask them not to stop, or please continue using the DOAC before colonoscopy, or how do you do this kind of thing in your unit?
So in our hospital, most of the patient, because we are the referral cancer specialized cancer center, so most of the non-GI doctor usually refer the patient to us, OPD, and then we really arrange the schedule. And also, when ordering the colonoscopy or endoscopy, there is a checkbox, patient taking antithrombotic or something. And then if it is checked, there is an alert that you should, provide some, informed consent form or something. Or if there is any question, please ask the GI doctor or something. So that is maybe, prevention.
But for Yoji Center, Yoji, you now have a new trial that asks patient to stop DOAC, not before, but after the procedure. So how do you disseminate this kind of information to our other doctors who are not familiar with your trial? I think this kind of thing is quite important. Yeah.
Yes, actually, I individually use such strategy for my patient, and the most important thing is to publish my paper, my RCT on the for the paper. But probably we need to the guidelines. So still now the guideline recommends cessation work before the colonoscopy. So people, doctors should follow the strategy. But in the future, if my paper is published, then maybe we can change such strategy.
Yes. And for patients who had previous experience of colonoscopy, they very frequently routinely stop aspirin by themselves, even though we advise them not to stop.
Yes.
So this is the problem. So especially for non-GI doctor, for cardiologist, even cardiologists, ask the patient to stop aspirin if they think that their, the previous cardiac procedure is very successful and very safe. So I think we have to think about how can we, deliver our service in the same way, and secure that there is no discrepancy in advice or in recommendation on DOAC or aspirin, before the procedure.
Yes. For us in Hong Kong, we will give a checklist to the patient with some information. They have some special drugs. Usually the doctor will have to take it and mention how for interruption for how many days. Somehow we are following the European guidelines, so we tend to stop the DOACs or the other drugs for longer. But for aspirin, we will continue it during the procedure, unless it's recruited to Professor James Lau's trial. Yeah. Yes.
Okay, I'm doing a mega trial looking at stopping or continuing aspirin for screening colonoscopy using cardiovascular risk as a primary endpoint. So I'm needing about 5,000 patients. So hopefully before my retirement, you'll see my paper.
Yeah, Louis will continue.
Louis can certainly continue.
Try my best to help.
Yeah, I think I thoroughly enjoy the session, and I allow Louis to conclude. I think the talks and the papers involved were all excellent. As mentioned by Harmo, and some of these trials that were actually practice changing, and they actually change how we think about the problems. Thank you, both speakers. Louis, do you have anything to say?
Yes, thank you again for our two excellent speakers. I think we have so many take-home messages. For the first talk, we know that for gastric ESD, this is kind of the ultra high-risk procedure, which we should rethink the strategy of the aspirin interruption. And for the second talk, on the contrary, we somehow lower GI polypectomy is not as dangerous as we thought. So the continuation of anticoagulants may help to reduce the cardiovascular risk. After all, I think we all know that we will need some evidence to change the guideline, and probably it may be time to change the Asian Pacific guideline on anti-thrombotics in the Asia Pacific with so many new evidences. And also the implementation of these evidence to the daily practice mentioned is also very important. So if there are no further questions, maybe we can close this session. And I would like to thank again our two excellent speakers.
Thank you.
Thank you.
Thank you.
Thank
My
you.
pleasure.